All right, so maybe we'll go ahead and get started. Hi, good morning, everybody. Welcome to our fourth session for the TB 101 series we've been running this summer. Today, we're going to be addressing the topic of treatment of latent TB infection. So we do have some polling questions towards the end and another case discussion. So just want to, I know a lot of folks have been putting questions in the chat, but just really want to encourage you to unmute and also, share your questions verbally. We're hoping that this will be hoping to have more interactive discussion with you all. And just a reminder that the Shweta just put that in the chat, that the session from last week, which was testing for LTBI, is archived on the TB 101 page on our website. So go ahead and introduce our speaker for today, who is Dr. Alfred Lardizabal. Dr. Lardizabal is the Executive Director at the Global Tuberculosis Institute and an Associate Professor of Medicine at New Jersey Medical School at Rutgers. Has many years of experience in treating both LTBI and TB disease, and actually was among one of the first physicians in the that I know of who was using some of the shorter course options for LTBI. So I'm going to turn it over to Dr. Lardizabal. And again, feel free to put any questions in the chat, but also feel free to unmute to ask any questions directly.
Great. Thank you, Anita. And good morning, everyone. Happy Friday. So for this installment, we're going to tackle treatment of TB infection. Your previous sessions touched on epidemiology and transmission. And so the patterns and trends of TB, both domestically and globally, are important in factoring in your decisions with regards to where to proceed once you do TB testing. The trends, epidemiology, followed by the understanding of transmission and pathogenesis are important background information to understand why we treat TB infection, latent TB infection. For this session, we'll tackle a couple of things, aspects of planning pre-treatment, understanding what the adverse effects of the various treatment options are, focus on the priority treatment considerations for latent TB infection, how we monitor once we start them on treatment, and we'll end up with a few scenarios and cases that hopefully will be an interactive part of this session. So our current approach to the treatment of latent TB infection was recently refreshed in 2020 with new guidelines that the CDC had put out. There are a lot of available resources out there. The one on the upper left is from the CDC, the MMWR, and the links are down here below for you to access if you're interested in the actual document. On the upper right is from the National TB Coalition of the US, and the one on the bottom are guidelines that the HIV group had put out as well, that touches on how to treat TB as well as latent TB infections in HIV positive individuals. And all of what we'll talk about today come from all these various resources. So what do we do in the pre-treatment phase? So you identify an individual with risk for TB infection. You decide to pursue testing. Either they're spent years in a high incidence country, or they were close contacts to an active infectious tuberculosis case. So you go ahead and treat. So once you do the testing and you have a positive result, the next step is to now make sure that you're dealing with latent TB infection and not TB disease. And to rule out TB disease, you have to do your history and physical exam in some cases. Chest X-rays are important components of this process. And if for some reason you're uncertain based on maybe a spot on the X-ray or complaint of 2 weeks of cough, then you may have to rule it out by using cultures in the micro lab. Asking about prior testing and treatment is also important in this whole process, because it may factor into your treatment consideration. So always make that a part of the assessment, prior history of exposure or treatment. The next important component of this preparation is to identify risk factors for adverse events, primarily for TB infection treatment. It would be hepatotoxicity or liver injury. And so, certain aspects of the patient are important: behavioral, alcohol use, drug use, the presence of chronic Hep B or C. These are important bits of information to consider when you're starting. Does the patient have liver disease other than alcohol-related cirrhosis? This may prompt us to do closer monitoring of patients such as these with liver problems. Are they on other medications that can interact and perhaps increase the risk for adverse events? So medications that are very common these days are statins for hyperlipidemia. So these are things to jot down before starting patient on treatment. Other medications are likewise important, particularly if they have interactions that may be significant when using erythromycin. A lot of agents such as anticonvulsants and anticoagulants are an example of drugs that will interact with erythromycins. The next step is to counsel the patient and educate the patient and make them understand what this whole process is about. That's the best way to mitigate serious adverse events and perhaps get them to participate in their treatment and get to the end of completion of treatment. So that starting point, that counseling is important as well. Both you as a clinician or as a provider and the patient need to weigh the risk and benefits, discuss why it would be beneficial, and perhaps alleviate some concerns about toxicities with treatment, since they are essentially healthy and asymptomatic. So nobody really wants to jump into something where they are concerned that they may just be harmed by the treatment. So a lot of reassurance is important to start with here. Baseline labs, generally, we do in our practice here in Newark for everyone, but certainly very important if you're treating individuals with liver disease, pregnant or postpartum These are people with higher risk of adverse events with the liver. HIV infected individuals, those that I mentioned earlier, alcoholics, need definitely to be tested at baseline. Others that are important to do baseline testing and close monitoring on are the elderly who are placed on LTBI treatment. So how do we exclude TB disease? Start with history and physical. You know, what's the risk for infection of this individual? What's the travel history? Are they on immunosuppressive agents, steroids, perhaps for multiple weeks already, or on biologic agents? These are important starting points. These are important bits of information to include as we start tackling TB infection in individuals. Symptoms, obviously, a productive cough, 2 or more weeks. Those are the most common uh, symptoms that accompany TB disease. Pulmonary TB is 80% of TB cases, so that's usually your first step. Fever, night sweats, weight loss, fatigue. These are other symptoms that might suggest TB disease. How long have these symptoms been going on? TB symptoms don't just occur for a couple of days. They're more subacute. They present for a couple of weeks at least, sometimes longer. So the duration of symptoms is also key in your assessment here. In terms of eliciting symptoms, bear in mind that although pulmonary disease is the most common form of TB, 80%, as I mentioned, they may also have some signs of extrapulmonary disease. Most commonly, by having lymph nodes that are swollen, very frequently they're cervical lymph nodes in the neck. So these are things to look for as well if you're trying to rule out a disease. Less common are CNS TB, obviously, and bone and joint TB, which might present as joint pain and swelling, and for CNS TB, headaches and confusion. But again, as I said, not very common forms of tuberculosis. In terms of physical exam, it would be, weight loss. Do they look ill? Most of the time, lung findings in somebody with TB disease are not helpful. The auscultation isn't very helpful. They usually have normal breath sounds. Radiography is also an important component of your assessment. So the chest X-ray for most LTBI will be clear. The lung parenchyma is clear. There's no pleural effusion. So that's the baseline. Now, if there is an abnormality, fibrosis or a nodule or granuloma, it would be helpful to make sure it's stable by comparing it with a prior X-ray if available. And this is a situation we commonly come across when we are assessing the new arrivals, the new immigrants that have a B1 status, which is quite frequent. And then within 3 months of the X-ray, you should have the treatment started, and assessment and treatment started. So you can't base your assessment on an old X-ray. So for the most part, we at the oldest age of an X-ray to be used should be about 3 months. Again, if there is anything concerning at all for TB disease, then proceed and rule out TB disease, generally by doing sputum collections, cultures, and PCR on the specimen. You may need to do use other tools like imaging as well, if needed. So that's our starting point. What are the adverse effects of the various agents we use? For the most part, we're looking at liver injury as the more important adverse events with regards to the use of INH, rifampin, rifapentine. It's important to remember that for both INH and rifampin, once you start them on treatment, they will have sort of this hepatic adaptation. The liver function will rise a little bit in a good percentage of patients. Up to 20% will have an elevation, which is part of kind of the adjustment of the organ to the medication, and then it will just kind of like stabilize and normalize. So that's the reason we don't just routinely monitor LFTs, because that's what you'll see arise, and then it might cause confusion as far as what to do with it. So that keep in mind that once you put a patient or anyone on agents, the antibiotics that go through hepatic metabolism, asymptomatic elevations are not uncommon. Clinical hepatitis with isoniazid, very uncommon. Again, and this has to do with the pre-existing risk factor, but on the average for everyone, it's anywhere from 0.1 to 1%. Again, if the patient is older, has other comorbidities, are on other medications, as I mentioned, then that calculation is a little bit different, and you have to keep a closer eye on these patients. Severe fatal injury to the liver is rare, but obviously has occurred and is what people are concerned about. But again, it's important to reassure patients by using evidence and the facts, and the fact is the rate of injury is very low. It's an acceptable number, and we control it by our process of monitoring. The last adverse effect that we generally try to control when we use isoniazid is peripheral neuropathy. Again, as you can see here, it doesn't really happen that much, less than 0.2%. People who are HIV positive or diabetic or pregnant have a higher predisposition to develop neuropathy, and in these individuals, they're the key patients that definitely will benefit from supplementing pyridoxine. Although standard practice for us here is to just pair it with isoniazid on everybody. For rifampin, again, alterations in the LFTs, particularly bilirubin levels, do rise with rifampin in a small number of patients. Rifampin in itself causing clinical hepatitis occurs even lesser than isoniazid. Certainly, when you use both drugs, the rate will rise a little bit, but rifampin on its own, compared to isoniazid, causes far less liver injury than isoniazid. A common problem that patients might report to you when starting them on rifampin would be sort of a complaint of pruritus, and that generally happens as we start patients on treatment. So it's self-limited. Again, counseling and reassurance always helps. And if needed, control the symptoms with antihistamines and things of that sort. Hypersensitivity reactions may occur, but they're not common as well with rifampin. Finally, a side effect, not an adverse effect, is the discoloration of body fluids, particularly urine. I mean, that's really what the patient will observe immediately, is that the urine looks darker, and it's always helpful to tell them ahead of time that that's expected, and that's not a sign of any problem. Third, isoniazid rifapentine weekly. Again, compared to INH, INH rifapentine once a week had much lower rate compared to INH when it comes to hepatotoxicity. Hypersensitivity reactions were higher compared to INH when the rifapentine INH combination was used. And it's primarily due to the rifapentine component. And then, as with rifampin, the urine again will have a discoloration, so something to remind patients. So for the general patient population, adverse effects, serious adverse effects are minimal, and mitigated and controlled when we educate properly and we have a monitoring process in place. Treatment options are next to be discussed here. Again, this is from February of 2020, a publication that kind of listed, rearranged the treatment regimens based on recommended to less recommended using evidence. And so here is our ranking. The top three are the preferred, okay, and very, very good evidence for the top two. The recommendation, as you can see, for 3 months INH rifapentine once a week is very strong, as well as the 4 months of rifampin given daily, a very strong recommendation to go with. All right, and so the alternatives, should you have to, is to move to the 6-month treatment with isoniazid here. It has a long track record, good evidence, and that earns it a strong recommendation as an alternative treatment. So why did the three end up on top? The rifamycin-based regimens are essentially the shorter treatment regimens in your option bucket. And so that's what we're going for. Shorter treatment, completion of treatment, and minimal risk for adverse events. So we go with the rifamycin-based regimens, the top three. And we'll go through each of them one by one. So 4 months daily rifampin, 600 milligrams a day, is generally well tolerated. Again, I mentioned earlier, less hepatotoxicity when compared with INH. Clear improvement in adherence and completion rate and tolerability when using 4 months of rifampin. Again, as this drug, rifampin, and all the rifamycins, these are important. It's important to remember that they are rifampin is a very strong cytochrome P450 inducer. The cytochrome P450 system is an enzyme mechanism in the liver that when a person is on rifampin is given more gasoline. It just it is revved up, so it metabolizes other drugs much quicker, and so people on oral contraceptives, on warfarin, on methadone, all these drugs that go through the liver as well for metabolism, they will get affected. Another group that's also very important to keep in mind is a lot of antiretroviral agents also get metabolized by the liver. So it's a very important consideration when patients are on all these other drugs, in order to help you kind of make an appropriate choice with regards to treatment for latent TB in patients such as these. The one option, I was going back here, although rifabutin is used as an alternative to rifampin, again, rifabutin is an inducer of cytochrome P450, but induces much less so than rifampin. And sometimes this agent can be used as a replacement, and then you can get away with other things with less interaction. So that's something else to keep in mind. The evidence, though, for rifabutin specifically in randomized control trials is not as strong as rifampin. 3-HP is what we commonly, the nickname we use. It's INH rifapentine weekly for 12 weeks. So this is the shortest today, the shortest and least amount of doses that we have as a regimen for preventive treatment. Although it's short, its negative aspect is the pill burden. So when discussing options with patients, these are things to put on the table. Short, non-inferior to INH, less hepatotoxicity compared to INH, improved adherence and completion versus pill burden. And so some patients don't mind the 10 pills, but others have a problem with that. And so it's something to kind of clear up before choosing the appropriate drug regimen to use in these cases. The reason it's 10 pills at a time is obviously you have to adjust the dose for the weekly administration, as well as the fact that rifapentine only comes in 150 milligram tablets, so you need about 6 of those to get to the 900 milligrams you need for kind of an average size adult. The caveats with 3-HB, not yet approved for children below 2, pregnant patients, and HIV on ART, unless they are on specific ones such as the Favreds and dolutegravir. These ones you can use 3-HB. Other drug interactions, as I mentioned, rifapentine will do it as well. So it's another thing to consider when choosing your regimen. As with rifampin, oral contraceptives, methadone, Coumadin, antiretrovirals, they all will have drug interactions. So in the hierarchy of things, rifampin is the strongest inducer, followed by rifapentine, followed by rifabutin being the least. Other aspects of this regimen that have been an issue lately is the availability. So supplies of INH, for instance, in many parts of the U.S. have been challenging in the past 6 months. So that had led, that had affected the choice of treatment as well. Rifapentine also had an issue with availability and contamination at one point. So the Prevent TB compared 3HP to 9 months of isoniazid. It basically statistically said it's non-inferior. Although there was a trend to superiority actually with the 3HP regimen. Again, the results, the adherence was better. Hepatotoxicity was not similar. The actual results were less hepatotoxic compared to INH, but more drug adverse events with regards to the hypersensitivity issues with 3HP. All right. So again, 12 weekly doses, and the dosing guidance is here on the slide as well. Now, the last of our options would be INH, and in about maybe more than 5 years ago, we were giving 9 months of isoniazid, and with the adjustment of recommendations in 2020, they put 6 months of INH as more preferred compared to 9 months. Again, the reason behind all that is completion of therapy. We've had, when isoniazid was our prime, our preferred drug, our drug for preventive treatment of TB, it was what we used about 15 years ago, and around that time, we were seeing really poor completion rates. They would get the first month and never come back. So when there was some signal that rifampin might be an option, we right away tried this. But 2006 is when we wrote about our experiences in New Jersey, and really back then, those on INH only finished, only about 53% completed their treatment. And so compared to, I believe, if I'm not mistaken, about 80+% of completion on the rifampin side. So that really changed practice. And over the years, more and more data has come out to support the use of rifampin as a primary agent for preventive therapy. Okay. We used 9 months before because in the early study day, in the trial days when they were testing INH, they had 6-month time point, and others got 12 months. And what they saw was there was a difference between 6 and 12, but between the angle of the slope of difference started to flatten out after about 9 months. So they kind of extrapolated the results and kind of say, okay, let's just use 9 months. But again, as you can see, our practice is to try to get it shorter and shorter. And so this is really our goal, is to treat as quickly and as short as possible. And so our rifamycin-based regimens are the main agents. I mentioned this earlier that we saw adherence rates improve It's Fregonase and Menzies from McGill that actually did an RCT on a good number of adults, 6,000, comparing 4R and INH. And this was published in 2018. Again, this is one that we were seeing as working, but this study kind of uh, uh, was evidence that it did. And so they compared, just as they did 3HP and 9H, they compared 4R and 9H here, and again, non-inferior. So that really is an important milestone, and backed the rise of rifampin as far as the treatment of choice. Here is are the results that came from Prevent TB, the study that compared 3HP and 9H. And you can see the efficacy was similar, significant improvement in adherence and completion, less hepatotoxic 3HP. But as I mentioned earlier, more of these nuisance reactions like a rash or a flu-like complaint on the 3HP arm. For most patients, they will start complaining after their first month or so, and then sometimes we're able to keep going by symptomatic treatment. Certainly making sure that nothing more serious is going on when the patient starts complaining by doing labs. Very rarely, as reported, syncope and hypotension. This is considered severe. It's rare, and obviously if this occurs, you'll have to stop. The Prevent TB trial was carried out in a controlled setting. All 12 doses were administered using directly observed therapy. So when science puts out results in terms of a comparison of different regimens, it's the next step is, how do we use the drugs? How do we use these regimens? And as we rolled out 3HP, initially everyone, it was recommended that it be given by DOT. This trial by Belknap compared DOT, self-administered therapy, or electronic self-administered therapy, where they would get messages, and found that really there was no difference between self-administered therapy and directly observed therapy with regards to making them more adherent. So it again was added data to guide our implementation and practice today. So there's a lot of guidance available, resources available from the CDC, and this is just a brief kind of brochure on it. Patients can access this. Other resources that you might consider using is your medication tracker. It's kind of a diary, and so it kind of is another tool to help in adherence and completion of treatment. And other ways to control and mitigate problems is providing them with these types of tools. They could do a read through this every time they're taking their medications, and certainly it prompts them to notify the provider as soon as some complaints develop. Mentioned this by Swindles from the Hopkins group. 1 month of rifapentine isoniazid daily. Rifapentine here is 600 milligrams. INH is 300 milligrams given daily. for a month. Very promising. Didn't make it to the recommendations. Particularly, there's still some concern as far as whether it's a generalizable result. The population that this regimen was tried on was HIV infected with an average CD4 count of about 500, 400 plus. And more than half of this group were on efavirenz or dolutegravir, some antiretroviral. So that's the specific group that this 3HP was, I keep saying that, this 1 month rifapentine INH regimen was tried on and found to be non-inferior to a 9-month regimen of INH alone. It's important, but I think there's ongoing trials to use it on other groups of patients to kind of just validate the regimen as effective. So for LTBI and HIV, the preferred currently for us here in the US is 3HP weekly, or 3HR. Again, the problem here is the R, the rifampin and its drug-drug interactions. And then the alternative, if there is significant drug-drug interaction, is to essentially use isoniazid. In some patients, in some clinicians' practices, they will probably go for the 1HP if they were treating an HIV-infected individual with the same profile of the study that we mentioned earlier. And then finally, the 4 months of rifabutin might be considered, but is not part of the recommended regimens in the HIV guidelines. So when you choose, it's really the rifamycin-based versus INH, shorter, better adherence. The rifamycin-based regimens have less hepatotoxicity. And from all the trials that have been mentioned so far, their efficacy is equivalent or non-inferior, if you want to be technical about that. But if you boil everything together, the short course regimens win in terms of the preferences. I'll mention that INH and rifampin regimen that is also part of the recommended treatment regimens is certainly an option, and there is some evidence to support that. The UK has been using 3 months of INH and rifampin for some time now as part of their recommended preventive regimens. And only in 2020 did we include INH rifampin as more evidence came out to support that. Some clinicians will opt to use two drugs if there is some evidence of prior TB disease, like old healed lesions on the x-rays, and your cultures are negative. Some will still use 2 drugs in those cases. Treatment follow-up, essentially baseline monitoring, and if everything is okay, monthly assessments, clinical assessments. It's symptom checks, checking on their adherence, checking whether the bottles are empty when they come back. These are part of the monthly rituals that we do. Again, aside from looking for adverse effects, it's also always looking to rule out active TB. So asking for adverse effects, do you have any cough? These things can occur and in the middle of preventive treatment therapy. Okay. Lab monitoring may be required if the patient is complaining of something. We generally will review and repeat LFTs if they have GI complaints, or even if they have cutaneous complaints. We would go ahead and repeat liver function testing there. Always review the patient's medication list if anything has changed since the last time. I mentioned this earlier. Appropriate patient education is always kind of the key here, because you essentially touch base with the patient only once a month, and a lot of things can happen in the 4 weeks in between. So the patient being equipped enough to decide something bad is happening is the most important way to control serious adverse events. So most people on treatment will have minor complaints. A majority will not have any, but these complaints are, for the most part, minor and controllable. As we already mentioned, severe adverse events occur much less, again, in the range of 1 to 2%. If it's minor, you continue treatment after your assessment and manage symptoms. If it's pruritus, antihistamines. If it's a GI intolerance, it's simple things like taking with a snack or adding an H2 blocker or omeprazole to control the GI intolerance. More severe problems, again, have to do with liver. If the LFTs triple the upper limit of normal, we're specifically talking about ALT, and the patient is complaining of nausea or has other symptoms, that diagnoses drug-induced liver injury. If there are no symptoms, a 5 times rise in ALT is what would be considered significant. So if these things occur, you do have to stop, monitor for resolution, and then decide alternative regimens. Like, you have to sit the patient down again and say, here's what we have and here are our options. Then go from there. So how do we define treatment completion? We have set number of doses. 3 HP is 12 doses. 4R is 120 doses. All right, and 3 months of INH and rifampin is 90 doses. So these are kind of your set doses, but the timing is also considered here. And so for 6 months of INH, the 180 doses should be completed within a 9-month time frame. For R, 120 doses, 4 months of daily rifampin should be finished within 6 months. So barring some interruptions there. And then 3 HP, 12 doses should be completed within 16 weeks. Again, nobody really did randomized trials to say, finishing it exactly at 6 months versus 9 months is equivalent. This guidance is based on expert opinion. So always keep that in mind. And if there are too many stops and starts in a patient's regimen, you might have to really reassess and focus back on the overall risk of progression to TB disease and find a solution. So with that, I think we move to some case scenarios. We're heading to about 8 minutes to 10. So how do we do this, Anita? We'll do each case at a time, and we're going to poll.
Yes, yep. I'll be pulling up the polls after we go through each question.
All right. So let's start off with the first scenario here. 50-year-old man with atrial fibrillation and latent TB infection. For atrial fibrillation, he is on anticoagulation with Coumadin. He goes to the office. His schedule is a barrier for frequent visits. So what would be an ideal regimen for this scenario? So heart disease on anticoagulation. Only one answer. Oh, nobody's answering.
Okay, I'm going to end the poll in a few minutes.
Have they voted?
Yep, I'm going to end it now, and then I'm going to show the results.
How many do you have? I don't see the numbers.
Yep, I'll share in a few minutes.
Okay.
In a second, yep. Do you see the results?
Right.
Mhm.
Yeah, I mean, I agree. Broken down to most had gone with INH, and then followed by 3HP, and then 4 months of rifampin. Yeah. So the key thing to remember here is the fact that the patient is on Coumadin that we mentioned earlier, is also metabolized by the liver. If the choice is to go with a shorter regimen, it would require more tweaking of the dosing of Coumadin, meaning more testing, blood testing, making sure it's therapeutic, and then raising the dose of Coumadin. And that can be a little bit tricky when using rifampin. 3HP could be considered, but then that doesn't remove the fact that you still have to kind of make sure your Coumadin is therapeutic, so that once a week may lessen, but it'll still have some interaction. So I think if that's the case, I think INH probably would be kind of something to work on with a situation like this. So next case, 40-year-old woman with HIV infection on efavirenz. It's an efavirenz-based antiretroviral regimen and is newly diagnosed with latent TB infection. So a priority individual to treat, certainly for LTBI, right? It's good that the patient is on antiretrovirals and it's efavirenz. So what's a good option for this case?
Okay, I'm ending the poll.
All right. So yeah, it's kind of spread throughout, but most had gone with the shortest, 3-HB or 3-HR. Again, with efavirenz, so not all antiretrovirals are a no-no with rifamycins. And so efavirenz, which is a non-nucleoside reverse transcriptase inhibitor, is usable with rifapentine and rifampin. And so, yeah, the top choice of 3-HB or 3-HR is certainly you're going to be on top of that. The shorter it is that you do this, the better it is for the patient altogether. Okay. Again, don't hesitate to send in some clarifications if you have questions on the chat box, or feel free to unmute and or raise your hand if you want some clarifications. The third case is a 25-year-old man with a newly diagnosed latent TB infection. He's a contact to a coworker, and this coworker has INH-resistant TB. What would be your option? The options are 4R, 4 months of rifampin, 4 months of rifabutin. Based on expert opinion, consider overall risk of progression TB disease, or use fluoroquinolone like moxifloxacin or levofloxacin.
Okay, I'm ending the poll.
Sure. Yes, there you go. So a clear trend here, and definitely even back before rifampin ended up on the recommendations list for preventive treatment, it was certainly the drug you would use for isoniazid resistant exposure or latent infections. And so clearly 4 months of rifampin would be what you would go with if the strain is INH resistant. You know, the rifabutin question, again, in some situations, that's an alternate drug. Sometimes there's reactions to rifampin, and we shift to rifabutin, but it's not like your first go-to in terms of preventive treatment. It's an alternate, and so it doesn't win a position on the recommendations list. So we'll go to the fourth. 67-year-old woman with latent TB infection who does not like taking pills. What do we do? Put all the options on the table, all the different regimens, consider risk of progression, and then decide to treat or not. Maybe just require further discussion, and then all of the above. Yeah. Yeah, I think the age, this is not too old. You know, there are people that are sent to us that are 85, and I don't think, you know, preventive treatment will kind of really make an impact at that point. But 67 is not an old age. It's certainly still a lot of benefit to be derived with preventive therapy in this patient. Now, I think all of the above is the right choice, because you really just have to put all the options on the table, you know, discuss again why you're pursuing treatment, and then mutually decide on the route to take based on the discussion with somebody who's a little bit of hesitation with taking pills. Yeah, once they're on it, essentially once they get going, it really is a smooth sailing for many individuals, most individuals, I'd say. So just a lot of counseling and discussion helps. Okay, we'll go to the last part here. Oh, here are the answers. All right, here's a kind of a real life scenario, but I hope in this last part, I can hear some voices chime in. Don't hesitate. Be nice to know what you're thinking. So here's a 45-year-old woman with a history of hypertension, diet-controlled diabetes. She's a household contact to her mother, who was diagnosed with active pulmonary TB. This 45-year-old woman was never treated for TB nor LTBI in the past. She's asymptomatic, no cough, no fever, no night sweats, no weight loss. Her IGRA, TB IGRA is positive, and her chest X-ray is normal. So based on that first paragraph, she essentially has LTBI, and because she's a close contact, she's a high priority LTBI patient in terms of to be treated. So you evaluate the patient, you counsel, provide the options and education, and she elected to go with the 12-dose weekly regimen with isoniazid and rifapentine. She's given a month of medications and the clinic contact information and the other tools to get started with the treatment. After the second dose, the patient reports itching all over, no rash, but it subsides the next day. What would you want to know? What would you do next? Unmute or enter your thoughts on the chat box. Oh, here. Patty, are there some chats?
I do have some questions.
Oh, okay. I want somebody to, okay. The itching is a nuisance, but tolerable. Would you stop? Would you continue and treat? Okay. Yep, continue, give Benadryl, and yeah, that would be my approach as well, is to continue treatment, and the symptoms seem to be minor and self-limited.
Was there fever, mucosal involvement?
Yeah, no, that's important, and I think that's what would you do next. Is part of that is to kind of have an assessment of the patient as well.
Did the patient start any new food or medications?
Yep, those are always things to incorporate in your assessment. Is there any other potential cause for this complaint? There's no abdominal pain here. Is that what it is, right? Right,
Yeah.
upper quadrant.
Mm-hmm.
Yeah, this scenario is just cutaneous pruritus. So yeah, I think the things in general, the approach is not to stop treatment immediately, but part of that decision has to be backed up by an assessment. The assessment is, again, history. What's the behavior? Is the rash generalized? Is the rash limited to the arms and torso? Does it include the mucosa, the mucosal surfaces of the mouth? If so, it's more severe if that's the case, and that's an indication to stop. Is there anything else that could have triggered this? New drugs? Did they go out on a trip? Is there something else that might be triggering the symptoms? And then proceed with your decision. And generally, the decision would be symptomatic treatment, continue the regimen, and monitor. Next. So she gets assessed. There's no rash, no skin lesions. She takes her third dose on time with no further pruritus. You're also treating the patient's mother who has active TB, smear positive, and it's not rifampin resistant by expert. But into like the 6th or 8th week of this diagnosis, she's found to be isoniazid resistant. So what do we do with a contact at this point? Would you want any additional information? Again, any answers there? Again, in this situation, now you have a resistance in the strain that the patient's exposed to. You're going to have to kind of reassess the choice of treatment here. And as part of that, again, ask again the patient's history, whether she's had prior TB or prior TB testing. Is this definitely from exposure to the household, the mother? A lot of times, particularly in our foreign-born populations, it's hard to tease that out. And so these types of questioning, these types of reevaluation is kind of helpful in terms of guiding your decision moving forward. So the assessment is that this is a recent infection, most likely from the mother, and she has isoniazid resistant LTBI. What changes do you want to make? She's on 3-HP, right?
So you could put your answers in the chat. She's on 3-HP right now, which includes INH. And she's resistant. So now I see some, I would want to switch to 4R, change to 4R. I would want to make sure the patient does not have active TB symptoms.
Mm-hmm. That's important. Yeah, that's every point of the way as you're managing these patients. Always have that in the back of your mind. Is any concerns for TB disease here, right? Sure that we're going to make a shift, and the shift is going to be rifampin. But as part of that process is kind of that rear view mirror. Are we sure that there's no occult or active TB that's brewing because we were treating inadequately? So in this case, the patient goes with 4R, as most of you had thrown into the chat box, which is the right path to take. And she finished 3 doses of 3-HP. She asks if she needs to take the full 4 months of rifampin. What would be, what do you think? You had 3 doses of 3-HP. She's asking maybe I can just take 3 months of rifampin. Is that?
Well, so far the general consensus seems to be complete 4 months.
Oh, good.
Mm-hmm.
Yeah. I think at this point, three doses so far is not anything substantial, on top of the fact that the strain is isoniazid resistant. There's some instances where the patient has already gone through like half of it. That may have some effect, and maybe some clinicians may consider that and just continue with the other regimen, particularly if they develop adverse reaction. So one more scenario here. If the patient had pan if the source case had pan-sensitive strain. But there was a rifapentine shortage problem with supplies after her third dose. What would you go with? I think the approach would be if you don't have rifapentine.
So that's really not an unrealistic problem because that does come up.
Yeah.
But as a nurse case manager, I'm just going to throw out there, if you're going to put somebody on rifapentine with these shortage problems, please make sure you have 3 boxes to complete so it doesn't happen.
Yeah. Yeah.
Slide for that patient.
Yeah. So that last line is really a reflection of current issues in terms of drug supplies nationally. So the supply issue should be also factored into your decision making in terms of the regimen of choice, obviously. So finally, the patient is on rifampin daily for 4 months. She looks like she's having a hard time with her adherence. She's missing doses. What might you be able to offer?
A med tracker, phone reminder. Let's see, we can maybe try DOT. Supply her with medication tracker, call her more frequently to monitor, discuss barriers to remembering to take the medication.
Correct.
Setting daily alarms.
Great. Those are excellent suggestions. Before the DOT part, you could probably consider what was earlier mentioned as a medication tracker. Other strategies, text messaging, some calls. You might step it up to DOT, but again, it's labor intensive, and there are other strategies you might want to use to assist in adherence in this patient. So the patient completes 1 month of rifampin. She misses her next appointment due to work. She's feeling well, wants to complete the course. What do you advise her about her remaining treatment? So let's just move along. Again, in a situation where there's a little bit of shakiness, you have to rule out TB disease. Somebody in the chat said we could drop off her meds. That's certainly an option to kind of eliminate some of the barriers. The assessments can be made when that's done, and or use the phone and deliver the treatment. Again, the shorter the treatment, the better the outcomes. So opt for the shortest that's available and monitor periodically. So the biggest, in summary, the biggest challenge for patients that are going to be put on treatment for latent TB is the fact that they're healthy, and we have to sell them the value of treating and preventing TB disease. And so in order to get to the successful completion of this whole process, the starting point of educating in terms of the significance of what this strategy is trying to achieve is a very important starting point. Counseling and provision of tools and other strategies along the way to break down the barriers, again, will help patients get to the end of treatment seamlessly. Finally, to conclude, opt for the shortest available regimen that is acceptable for the patient, and that's what you need to go with. So with that, I think we have our last slide. Patty, anything else we need to address?
Well, we're at time, but there was one question. I just want to put it out there that the question was, would the recommendations of the LTBI treatment, the way they were laid out, that order be the same for children? But we are having Dr. Feha next week. I don't know if we want to speak to that. And then I can also, I just going to share my screen. I just wanted to show you, this is the LTBI card, and there's the QR code for treating children and adolescents. It's a product from GTBI. So I think it's a really good tool. But if you can address the child question.
Yeah, generally the same preference, except, 2-year-old or less still will be limited, not the 3 HP. I think Dr. Feo will touch on those issues next week. The younger the kid, the more challenges there are because of the pill itself. So the like 3 HP, for instance, doesn't come in liquid form, so that essentially will be a big challenge for kids. So that's definitely going to be factored into your decision there.
Okay, thank you. I think we're at time. We're a little bit past our time. So everybody just remember, same time next week. Thank you, Dr. Lardizabal, for that great informative presentation. Next week, we're doing treatment and testing in children with Dr. Feha. And these slides will be available. I forget the date, but the presentation, the video and the slides will be available at the GTBI website.
Thank you for listening. See you next week. Have a good weekend.
Bye, everybody. Have a good weekend.